Artificial Intelligence Dr. www.abcpharma.net/English. User question: Is the age-predicted maximum heart rate, APMHR, valid for patients with no atrial pacing? ClaudeAI answer: While the APMHR formula provides a general guideline for estimating maximum heart rate in healthy individuals, its application in patients with no atrial pacing is limited. The age-predicted maximum heart rate, APMHR, formula, which is calculated as 220 minus the person's age in years, has limitations and may not be entirely valid for patients with no atrial pacing, such as those with a unicameral leadless pacemaker. There are several reasons why the APMHR may not accurately predict the maximum heart rate in these patients. Lack of atrial contribution to heart rate. In patients with no atrial pacing, the heart rate is primarily determined by the intrinsic sinoatrial (SA) node function and the rate of ventricular pacing. The APMHR formula assumes a normal physiologic response to exercise, which includes an increase in heart rate mediated by the SA node and the sympathetic nervous system. Without atrial pacing, the heart rate response may be blunted or less predictable, as it relies solely on the intrinsic SA node function and the pacemaker's rate-responsive settings. Chronotropic incompetence. Many patients requiring pacemakers, including those with a unicameral leadless pacemaker, may have underlying chronotropic incompetence. Chronotropic incompetence refers to the inability of the heart to increase its rate adequately in response to physical activity or stress. In these patients, the actual maximum heart rate achieved during exercise may be significantly lower than the APMHR, regardless of the pacemaker's rate-responsive settings. Cardiovascular disease and comorbidities. Patients with a unicameral leadless pacemaker often have underlying cardiovascular conditions, such as heart failure, coronary artery disease, or valvular disorders. These conditions can limit the heart's ability to increase its rate and contractility in response to exercise, leading to a lower actual maximum heart rate compared to the APMHR. The presence of comorbidities, such as diabetes, hypertension, or pulmonary disease, can further impact the heart rate response and make the APMHR less reliable. Medications and autonomic dysfunction. Many patients with pacemakers take medications that can affect heart rate, such as beta blockers, calcium channel blockers, or antiarrhythmic drugs. These medications can blunt the heart rate response to exercise and make the APMHR less applicable. Autonomic dysfunction, which is common in older patients and those with cardiovascular disease, can also alter the heart rate response and limit the usefulness of the APMHR. Individual variability and cardiovascular fitness. The APMHR formula does not account for individual variations in cardiovascular fitness, genetic factors, or the level of physical conditioning. Some patients may be able to achieve higher heart rates than predicted by the APMHR, while others may have lower maximum heart rates due to various factors. The APMHR should be used as a general guide rather than a precise target. An individualized assessment of the patient's clinical response and functional capacity is essential. Given these limitations, the APMHR should be used cautiously in patients with no atrial pacing, such as those with a unicameral leadless pacemaker. The actual maximum heart rate achieved during exercise may be lower than the APMHR, and the pacemaker's rate-responsive settings should be adjusted based on the patient's individual clinical characteristics and response. In practice, a symptom-limited exercise stress test or cardiopulmonary exercise test can provide valuable information about the patient's actual heart rate response and help guide pacemaker programming. The optimal maximum heart rate setting should be determined through a collaborative discussion between the patient, their cardiologist, and the electrophysiologist, considering the patient's unique needs, comorbidities, and goals of care. ClaudeAI answer. The age-predicted maximum heart rate, APMHR, formula, typically calculated as 220 minus age, is a widely used guideline to estimate an individual's maximum heart rate. However, its validity for patients with no atrial pacing, such as those with unicameral leadless pacemakers, has some considerations. Validity for resting heart rate. The APMHR formula primarily serves as a rough estimation of the maximum achievable heart rate during intense physical exertion for healthy individuals. For resting heart rate assessments, this formula may still provide a reasonable reference point for patients with no atrial pacing. It can offer a general idea of the expected resting heart rate range for individuals within a specific age group. Impact of underlying conditions. The presence of underlying cardiovascular or respiratory conditions can significantly impact an individual's maximum heart rate. In patients with cardiac or pulmonary diseases, the APMHR formula may overestimate their actual maximum heart rate. For example, individuals with heart failure or coronary artery disease may have a reduced maximum heart rate capacity. In such cases, the APMHR formula may not be entirely valid. Consideration of functional capacity. It is crucial to assess an individual's functional capacity and overall health status. For patients with no atrial pacing, their actual maximum heart rate may be influenced by factors such as fitness level, muscle conditioning, and overall cardiovascular health. Their maximum heart rate during exertion may be lower than predicted by the APMHR formula due to these factors. Symptom-limited maximum heart rate. It is important to consider symptom-limited maximum heart rate, especially in patients with cardiovascular limitations. During an exercise stress test, the point at which the patient experiences symptoms like fatigue, shortness of breath, or chest discomfort may provide a more accurate indication of their physiological limits, regardless of the APMHR prediction. Rate response programming. In the context of patients with no atrial pacing, the unicameral leadless pacemakers are typically programmed with rate response algorithms. These algorithms adjust the heart rate based on physiological demands during activity or stress. The rate response settings, including the maximum sensor-driven rate, may be tailored to the individual's needs and can deviate from the APMHR. Individual variability. It is essential to recognize that there is inherent variability in maximum heart rates among individuals, even within the same age group. Factors such as genetics, lifestyle, and environmental influences can play a role. Therefore, the APMHR formula may not accurately represent the maximum heart rate for every individual.